Hi, my name is Anthony, and today I want to present on extracorporeal membrane oxygenation, or ECMO, anticoagulation monitoring in pediatric patients. For some background, extracorporeal life support is a technique that provides mechanical circulatory support to patients. It can vary from ECMO to LVAD to intra-aortic balloon pump. According to the 2020 ACLS registry report, there's over 70,000 neonates and children under the age of 18 support on ECMO. Of those cases, including adult, 54% of them are pediatric patients and 61% of those are neonate. ECMO is often used in pediatric patients who don't respond to optimal conventional therapy, and those patients can have either cardiac or pulmonary failure or have cardiac and pulmonary failure. As compared to adult, there are substantial difference in the indication, the setup of the system, and the site of catheter implantation. Typically, blood will be removed from the brain to be oxygenated, then returned to either the vein, also called veno-venous ECMO, in case of respiratory failure, or arterial or veno-arterial ECMO in case of cardiac and/or respiratory failure. On this slide, I just want to show that the blood are removed and then returned from the same site, which is the vein. And on this slide, it shows that the blood is being removed from the vein and then through the oxygenator and then returned back to the arterial side. What is the purpose of ECMO? It is reserved for patients with acute severe cardiac and/or pulmonary failure, despite being on optimal therapy. It's typically indicated for those with the mortality risk greater than 80% or may be considered in those with risk greater than 50%. We use it to help bridge the organ to therapy, giving it time to return back to original function, or maybe give it time to heal so then we can start surgery. Or we can bridge to decision where the patient may be put on a different device, or to give the patient time to think of a palliative care option. And lastly, maybe to give them enough time to receive an organ transplant. For some special consideration, it is contraindicated in patients who once recover from ECMO might not live a normal or same quality of life, or maybe in patients who age or size may be not fit for ECMO, or patients who are fertile or too sick and may have a fatal diagnosis. Also, we want to consider some complications, including bleeding or thromboembolism that can lead to infarction, infection, or anything related to cardiac and ischemia. Pharmacists can play an important role in ECMO since it is an invasive procedure which close monitoring is required. Bleeding and emboli formation are the major concern because the circuitry leaving a large foreign surface area that can allow massive inflammatory response to occur, which can lead to air emboli, clot formation, or hemolysis. Thus, we can play a role in help managing and monitoring anticoagulation to reduce morbidity and mortality in pediatric patients. A quick recap on the coagulation cascade. Our target anticoagulation are heparin and direct thrombin inhibitor. With heparin, they will bind to antithrombin, which then inhibit factor 10A and 2A, and direct antithrombin inhibitor will bind to factor 2A mainly. Heparin is a widely used medication in ECMO patients. It works on potentiate the action of antithrombin 3, which inhibit thrombin and factor 10A that prevent the conversion of fibrinogen to fibrin. The half-life is approximately 1 to 2 hours in adult, but it is faster in pediatric patients, and it can vary significantly between patients. The metabolites are eliminated renally at therapeutic dose. The elimination is occurred via non-renal mechanism. However, at higher dose, the renal play an important role, but renal dose adjustment is not necessarily needed in patients with renal impairment. And this drug have a reversal agent, which is a protamine sulfate in case of there's a bleeding complication. To manage heparin effectively, Close monitoring is required to reduce the risk of bleeding or clot formation. Typically, the patient will be bolus at 100 units per kg before initiation, and the continuous infusion will follow at 7.5 to 20 units per kg per hour. Depends on the patient specific information. If the patient at a higher coagulable state, you want to start at a higher dose to reach therapeutic, or if the patient have known low platelet level, then we want to start heparin at a lower infusion rate. And the titration is based on the coagulation panel by looking at activated clotting time or activated partial prothromboplastin time or the anti-10A level. First, I want to talk about ACT. It's a whole blood point of care test where blood is mixed with an activator to provide a global functional test of hemostasis. The goal is between 180 to 120 seconds. It is a low cost and rarely available. However, there are many factors that can affect ACT, including platelet count and function, the level of patient fibrinogen and coagulation factor, the renal function, and the hemodilution status. Next, I want to talk about is the APTT, which is a plasma-based test that uses activator and reagent to measure the time of fibrin formation in the absence of cellular component. Our goal, we aim to be at 60 to 80 seconds. It is available at bedside, but is much less reliable compared to laboratory drawn. Typically, each institution will have their own therapeutic range, so I recommend you following that. It is not as reliable in neonate and pediatric patients due to ATP typically prolonged because of the different level of fibrinogen and coagulation factor. Next is an anti-10A that measures the ability of heparin catalyzing anti-thrombin inhibition of factor 10A. It is a gold standard measurement, and our goal, we want to aim between 0.3 to 0.7 international unit per ml. Even though it's not readily available for an immediate result, they have much better correlation than APTT and ACT. And this is because anti-10A assay is not influenced by coagulopathy, thrombocytopenia, or dilution status. And I want to caution that this assay requires 8 antithrombin level, so it is important to consider antithrombin deficiency when anti-10A concentration are not raising when the dose of heparin are increased. And lastly, this assay might not be perfect due to its limitation that can be affected by hyperlipidemia, hyperbilirubinemia, and high plasma-free hemoglobin level. This can happen especially often in patients who critically ill and can falsely lower the anti-10A level. What is antithrombin 3 or AT? Antithrombin is an endogenous coagulation enzyme that inhibits thrombin and factor 10A. Once heparin and antithrombin complex form, it can decrease the thrombus formation, increase the tissue factor pathway inhibitor affinity to factor 10A, which can have a downstream effect on the coagulation cascade. Typically, infant has a lower AT activity compared to older children and adult. You may see this through an escalation in heparin dose, typically between 35 to 40 units per kg per hour, and or you may see a subtherapeutic anticoagulation, which can suggest there's a heparin resistance. At this time, you probably want to draw in antithrombin level, and typically we want it to be greater than 50%. And the replacement is vary between institutions. Some may want to start replace at 50%, some may go lower to 80%, and the goal is to be at 80 to 120%. Before starting the replacement, you want to decrease the heparin infusion before initiation. It can be done through fresh frozen plasma, cryoprecipitate, or a recombinant antithrombin. On this slide I have is thrombate 3 or recombinant antithrombin. For label indication, it is used in patients with hereditary antithrombin deficiency. The dose is based on the patient AT3 level and the patient weight, where we load the patient up to raise the level to be at least 120. Then the dose will be maintained and the AT3 level will keep between 80 to 120. Also, it also have an off-label indication where the patient have sign of heparin resistant during cardiopulmonary bypass. The dosing is much simpler, where the patient will receive 500 units once, then repeat if the ACT level is still subtherapeutic. There's no renal or hepatic dose adjustment needed. The infusion rate is between 10 to 20 units, and some possible side effects you might see with is chest pain, dizziness, hemorrhage, or hematoma. And while the patient on this therapy, you want to monitor for the vital sign, cardiac, and hemodynamic status. Along with heparin, direct thrombin inhibitor can be used under some circumstances. We have bilavirudin, which typically give as a bolus, and then followed by continuous infusion, or egatroban with a continuous infusion, and some institution might bolus the patient as well. For dose titration, it is follow the patient APTT, where we want it to be 1.5 to 2.5 times their baseline. For some pros, it can bind directly to thrombin, so independent of antithrombin level. They do not bind to other plasma cell proteins, which can increase the anticoagulation efficacy. They inhibit both clot-bound and circulating thrombin, and it is an alternate treatment in patients with heparin-induced thrombocytopenia. For some con, there's a lack of antidote or reversal agent for this agent. So in case of severe bleeding, dose reduction and discontinuation is warranted. For my recommendation, I would like to recommend to monitor for at least 2 different anticoagulation panels to have an accurate picture of the patient anticoagulation state. If you have any question, please feel free to email me and I would try to answer promptly. Thank you.